Hey everyone, good evening. Welcome to Hump Day Happy Hour with Dentists in the Know. We are a group of dental educators and practitioners who have dedicated our efforts to bringing the dental profession and our patients together towards better health and more reliable outcomes. My partners and I do this little program in the most informal way, usually over a little glass of wine like we have tonight. And our hope is to bring everyone in the know. I am joined by the lovely and intelligent Dr. Jennifer Bell. I am Dr. Jeff Horowitz. And missing tonight is all of you in the night. We want to talk about sleep. I think I've gone out.
I can hear you now.
You can hear me. Wonderful.
Yeah, you're good now.
Where did we leave off?
You're going to bring us all in the know.
Well, then it was all right.
Are you going to bring us in the know? What are we going to get to know about?
I am hoping, I am watching my internet service come up and down during this thunderstorm here from the new studio in Conway, South Carolina. Apparently haven't gotten all the kinks worked out yet.
Got to get those little hamsters running just a little bit faster.
We got to get things going. But why don't we talk for a minute? How you been? How was your week?
Week is good. Crazy hot. It's one of those, we've now hit, I'm just a little north of you in North Carolina, and we definitely have hit our stride of summer. And I'm not complaining because, to be fair, I've lived here long enough that we hit these types of temperatures in early June. So actually it was a really nice spring, like long spring, nice kind of ease into summer. And then it just hit the wall, straight on.
It's been pretty oppressive.
Yeah.
And what's crazy is that in our Myrtle Beach office, I don't know why there's one room that literally is about 15 degrees cooler than all the other rooms, and it doesn't matter. Like it's got to be like 62 in there most of the time. So it is like,
are y'all huddling in there now?
Yeah. It's like going from an icicle on your nose, the sweat turns to icicles. And so it's pretty frustrating, but what can you do?
Welcome to summer. But other than that, just I think I did 35 composites in the last 2 days.
Oh, wonderful. For the public, those are fillings.
Yeah. And 35 of them.
That's not a fun day for a dentist. I'm just going to say that as much as you don't want to go to the dentist and have a filling, we don't want to do 35 of them in one day.
We don't.
It is not as fun as it sounds like. It is not all glory and, race back to our homes in Kennebunkport.
Right. On our yachts.
On our yachts. So we can go back and do another 38 composites the next day.
No. It's no, it's none of those things.
So,
and there are a few things that you come home from that you feel physically sore. I feel physically sore.
Yeah. Well, it definitely takes its toll. So
sure.
I cannot do nearly the amount of restorative dentistry that I used to do without my neck just completely aching at the end of the day. And I know everyone's out there going, oh, poor dentist. Poor dentist. Wah. But it is. It takes a toll twisting your head and looking at all those little things all day long.
That's exactly right. Well, how are you? How are things?
Doing pretty good. In the middle of a few real business transitions in my world. So, for the public out there, I'd practiced in general practice since 1992. Did restorative dentistry, turned my main practice over to my associate. And I really became very involved in what I like to term functional dentistry and making people in general healthier. And so where I have really put my focus is in treating sleep apnea and TMJ problems and orthodontics. And that's part of what we're going to talk about today. But throughout all of that, I still practice some general dentistry, but for the most part, probably 80% of what I'm doing now, maybe 85%, is really just in that sleep and TMJ world. And the rest of my practice is in restorative dentistry. So a lot going on with that, a lot of transitions in my life, becoming, just the family general dentist that everybody came to, and really focusing my efforts where I think I can do the most good now. And it's just been a busy time, and we'll have a couple of offices in the Myrtle Beach area of South Carolina. And it's really been interesting. And so I spread my time, as you do, Jennifer, between education and patient care, and finally doing this, which is kind of bringing the dental community together and helping bring patients and the dental community together, hopefully answering a lot of questions along the way.
Absolutely. But it's what we've signed up for, I guess. And
It is.
honestly, the teaching part, I think, makes me a better dentist, holds me incredibly accountable to what I do, and kind of keeps me re-energized.
Yeah. No,
And,
totally agree. Totally agree. You
so
better know what you're saying when you're in a group of, you know, anywhere from 30 to 300
yeah,
people
you're
that are recording you and are going to quote you. And we have got, we've really got to make sure that we know what we're talking about when we put
for
information
sure.
out there. Yeah.
100%. 100%.
So, and that's our goal with this kind of consumer facing side of what we're doing with Dentists in the Know is we want to give the public the best information possible, and really let you know what we're thinking from our end, but also what are the resources and what are the questions that you should be asking when you go and see a dentist or of your healthcare provider. So that's what we're going to do. But what we normally do on this program, when we have dentists facing content, is we will usually offer news, which Jennifer is very well tied in with a lot of organized dentistry. So she always brings us a great little news segment and talks about what's going on within organized dentistry, what's going on within government, how it affects patients, how it affects insurance. And so Jennifer has a little segment for all of you today, and I think it'll be good. She always brings great information to the table, and I'm going to let her have at it.
Well, thanks so much. I'm always happy to keep us all super informed. After all, we are dentists in the know. So, a couple of dental adjacent news stories out there this week that I thought would be interesting to discuss. The first is more on the line of education. So, as you know, many dentists spend a lot of money to become dentists. In fact, the average dentist graduating from dental school today is close to $500,000 in student loan debt to obtain that education. Now, that's a pretty significant portion of money. Well, interestingly, a lot of people in the US are currently sitting on a fair amount of student loan debt. And we are entering a phase in which a lot of this loan brief stall out, I guess, which happened during COVID, where many of us were able to take pauses on our payments because COVID created a lot of financial burden. Well, that is no more. In fact, that actually started in October of the last year of Biden's presidency, and certainly is now transitioning through the Trump administration. We have many borrowers. In fact, it is estimated that now 6 million different US individuals with student loan repayment programs are in default, and at least 2 million of those will be entering the garnishment phase of that default, which is in excess of 120 days of no payment. Default happens after 90 days, 120 days goes into garnishment. So, for those of you who employ individuals who may have student loans, and for those of you who may owe on your student loans and haven't been paying on them, you might want to go check the paperwork, because we are entering a phase in which that is going to start to come to a head, I think. And we're going to see more employers starting to withhold up to 15% of your paycheck towards your loan repayments, as well as any tax refunds, Social Security payments, if you're receiving those. All of those will be susceptible to garnishment. So, unless the momentum changes, I think this could actually be a pretty significant challenge, which within the economic landscape, that will continue to see individuals defaulting on these student loans. They will impact your credit score as well. TransUnion was talking about that today in an article that I was reading, that these will ultimately start to show up on individuals' collection reports as well. So just a heads up on that. Another interesting news story that came out just a day ago, the new administration has met with over 50 different medical insurance companies in the US to talk about some changes that need to be made. One major change that came out of that meeting that has been quite a buzz is medical pre-authorization. For those of you who are not familiar with pre-authorization, that is usually a hoop that is required for patients and medical providers to jump through in order to let the insurance company know that that the medical provider or the patient is intending to seek care to have a certain procedure done. So we'll put it in context of tonight's show. If you came to Jeff's clinic and he ultimately decided that you needed a sleep device to help treat your sleep apnea, he would then need to complete a pre-authorization for many insurance companies that could take up to 90 days to receive a response back of whether or not you could be covered for that procedure. Well, the administration is saying no more of this. There should be a dashboard and a quick automatic answer. It's either a covered benefit or not, and transparency as to why that would not be covered for this patient. The hope is that it will cut down on an administrative burden for small practices, hospitals, and patients, but it will also increase access to care for patients who are waiting for those pre-authorizations in order to seek care. I'm super optimistic that these changes will benefit both the medical practices and the patients. I'm somewhat pessimistic that insurance companies will actually follow through on what has been asked of them. But it has been made clear that either they make these changes collectively as a group and negotiate a change that works well for all, or the government and ultimately the federal government is going to have to get involved to say that these changes are going to be regulated instead. Me personally, I'd like to just see the insurance company solve itself, but we'll see how this works out. The last news story of the night is, of course, that big beautiful bill is still sitting up in the Senate. It passed through the House and is now in negotiations in the Senate. Why do we care about the big beautiful bill here in the world of dentistry? Well, many dentists are also small business owners, and there are quite a few items of language in that particular bill that would have a direct impact. In particular, the SALT Act, which has been highly debated and highly contested over the last 3 or 4 weeks as this bill has evolved over time. As it left the House, they increased the cap to 40,000, which is the ability for a small business to deduct its property and local and state taxes out of its income so that it can reduce its federal tax liability. Well, they don't like that too much, so they reduced it. It was up to 40,000. They tried to push it back down to 10. Now we're sitting in this weird space where it is a deduction plus the greater of 40,000 or 50%. This now feels like I'm reading an insurance coverage. You can get one or the other, or 50% of the one or the other, making it super convoluted and more complex so that you can pay your accountant more money to figure it out. And with that, that's the news.
So one from column A and two from column B.
Correct.
And that
I
is,
mean,
yeah, garnishment. None of it sounds that great, JB.
welcome to the world. I mean, we could have talked about ceasefires, Iran and Israel. I mean, like there are tons of other
Yeah.
topics that we could dip our toe in, but I thought I would do medical adjacent, and that's what we've stuck with. So,
And yet all depressing.
all still very much all
Still very depressing.
depressing.
But anyway, great news segment. And I think it's particularly interesting what's happening with student loan repayment and the kinds of debts that we're seeing, now with the rising cost of education. So
Yeah.
everybody strap in. It's going to be an interesting ride for sure, and we'll see where it goes. But that was
Well, and the
awesome.
only thing that will ultimately change that is either we choose not to pay for that education, like it becomes too cost prohibitive to do it, or these defaults will force universities to have to relook at their payroll, their P&L and say, can we actually charge people while we're charging? So something will have to give.
Well,
Either
they've
attendance will be
also
down
been
or
pushed to lesser degrees. I mean, when
right,
you think about, there's a lot of people who actually consider now, do I go to medical school or, and pay for 4 years plus a residency that doesn't pay anything, that will keep me below the poverty level, you
right,
know, and do I incur, 400, 500, possibly $600,000 in debt? How long will it take me starting at 30 years of age
right.
to actually start contributing to some kind of a retirement after I've paid back the debt starting at age 30? And really, they're behind the curve of someone who maybe gets a physician's assistant or a nurse practitioner job that pays pretty well. They have less than half of the amount of debt usually,
Yep.
and they're able to start putting money away pretty quickly. So, there's a lot of that kind of weighing out and decision making that's having to go on. And quite frankly, medical reimbursement is not what it used to be. And
Right.
so the salaries don't always justify taking on that kind of debt and then having to wait until after 30 to start paying back that debt, and
Yeah.
then finally getting ahead to the point where you can actually start putting money away towards retirement.
Yeah.
There are school teachers that will have, at that point, 10 years in their retirement plan,
Yep.
that quite honestly, if they're putting a little bit away, will be in pretty darn good shape. And so, it's certainly not the landscape that it used to be, where people think, oh, you're in medicine, you're in dentistry, it's just boom. They're obviously very wealthy. There's a lot to consider. So great
Yeah,
segment.
I think you have to run the P&Ls now on that
Yeah,
investment,
yeah.
basically, and say if it costs me 750,000, which I think is currently the debt for a 4-year dental degree at NYU, and that's just for the
Wow.
dental degree. That's dental and living expenses, I think, for the 4 years at NYU. And then you add the cost of if you had to fund undergrad, if you had any other loans underneath that, a car loan, anything else, and you're just kind of putting your life on hold for a long, long period of time. And then it all hits. I mean, eventually people want to get married, they want to start families, they want to build practices, they want to build businesses, they want to buy a house, they want to participate in the economy and what we used to call the American dream. So it's becoming more and more difficult, even for what you would used to think were high income earners, to get to that point where that actually is feasible.
Yeah. No, all
So,
all great points. So we lured everybody in tonight, with a discussion of why a dentist would be speaking about sleep apnea. Why
do
would a
you ever
dentist?
get that question like, why are you talking like,
Not anymore, because I now have a
oh, because
practice.
you have a shirt that says sleep on it?
That's exactly it. Do you see that? And I've got a little
Yeah.
little
So
little
now
dreamy
it's not
guy on a pillow.
surprising.
Yeah, yeah. No, I've transitioned my practice really towards more of a healthcare model, which on some fronts is really, really fun for me and really exciting that I'm able to have the impact on people's overall wellness and health, even more so than I was able to have just when I was doing general dentistry. Um, but the biggest thing is that transitioning a practice from that general dentistry arena to a practice where I am mainly seeing referrals from other healthcare practitioners, they're not coming in and asking me that question. Many of them already know they have a problem. But when I started doing this, it was from the perspective of a general dentist. So just to kind of give everybody, the reasoning behind why dentists are even talking about sleep apnea is I think the best way to do this is by saying first what interested me and how I got into this. So in 1992, when I opened a dental practice, we didn't have any orthodontists. We didn't have any pediatric dentists. We had one in our entire county. Jennifer's heard this story. I'm going to bore her for a second just to give you all some perspective. And quickly in going off to Atlanta and learning about growth and development and orthodontic development, what I also learned is that a lot of children had airway problems because of tonsils and adenoids. I also learned about the temporomandibular joint, or the jaw joint as it's known. So um, during that time, I would bring that information back to my general practice, and kids who were having a tough time breathing because their tonsils were so big and they weren't allowed to get their tonsils and adenoids out because they hadn't had enough infections and they didn't meet the criteria for the insurance companies for them to have their tonsils out, we would actually expand their palates, and we would watch their airways actually get better. We would start to see them sleep better. And, having been in this for a long time, the gray hairs are worth something, because what I learned was that the kids that we were able to intercept and make their arches bigger, and in essence make their nasal airways better, reduce the size of their tonsils just through orthodontic intervention, those kids grew up to be healthier adults than the ones that we weren't able to intervene with. And so that was really interesting. We were doing that all with appliances from the 80s and early 90s, nothing really fancy, but we were fixing kids with skeletal deficiencies, both in a forward backward direction, kids who had chins that were too far back, and also in a widthwise direction. And it was amazing the impact that we had. And then I got to watch them grow up, and the ones I didn't treat be unhealthy, and the ones I did treat grow up to be super healthy. And so right around that time, as I was watching that next generation come through, um, we began hearing from the American Academy of Sleep Medicine, the governing agency for everything sleep, that we could, as dentists, begin treating patients with obstructive sleep apnea with some of those same appliances that would correct the skeletal deficiency, in essence, bringing the tongue out of the back of the throat, and use that as an alternative to CPAP therapy. And that was all the way back in 2005. So I became very involved in sleep dentistry at that point. And what I'd like to do is actually share a little presentation, just to kind of give some perspective on why dentists are really and truly the best gatekeepers for many of the presenting factors that can let you know that there might be an airway problem. And so what I'm going to do is share the screen here. And there's a couple of things. I mean, right now, there's about a 10% diagnosis rate for patients who have obstructive sleep apnea. That's pretty scary when you think about the fact that obstructive sleep apnea, if left undiagnosed or untreated, leads to so many other healthcare conditions. We know that in dentistry, or excuse me, in medicine right now, the average healthcare practitioner has about 7 minutes with every patient, maybe 8 minutes at best. Most of the solutions revolve around, offering a pill or some type of a quick fix for the presenting symptoms. You have high blood pressure, let's give you a pill for that. You have high cholesterol, let's give you a pill for that. You have a fast heart rate, let's give you a pill for that. You have high blood sugar, let's give you a pill for that. You're overweight, let's give you a pill for that. And so what we've seen, and particularly after the COVID situation, is that there's a little more distrust in the healthcare system, and people are really trying to look towards the root causes for illness and ways to make themselves more healthy. And we've been doing that in dentistry for a while now, and really trying to be more of a healthcare advocate than just a tooth doctor. So in dentistry, we began talking about the connection between oral health and systemic health. Looking for patients who might have an airway condition that could be compromising their health, looking for problems in the jaw joint that could affect their teeth and the likelihood that dentistry would be successful. So really, dentists have been working more towards being a healthcare advocate, because we get to see you typically twice a year, and we get to spend a little more time with you than just that average 7 to 8 minutes that a dentist, or excuse me, that a medical doctor does. Now, we don't want to take the place of medical professionals. That is not our role at all. But we do want to be a good adjunct and let our patients know when healthcare intervention or prevention could really be a useful tool. So, when we talk about the current trends in medicine, one of them is functional medicine. We're hearing a lot of talk about, again, looking at root causes for disease as opposed to trying to throw a quick fix at the symptoms. So that's been a really good trend to see in medicine. Unfortunately, most patients cannot afford to participate in the model that allows that. The model that allows that is usually seeing a functional medicine doctor who typically will not be in network with most insurance companies, or a VIP or concierge medicine doctor who can take more than that 7 to 8 minutes to get a good history and to really dig deep for the causes of disease in the first place. So that's where we are. And I urge you all just to really become kind of a healthcare advocate for yourself, understanding that inflammation and other behind the scenes causes, other than what your physicians may be talking about, maybe behind some of your other issues like gastroesophageal reflux, like your high blood pressure, like your arrhythmia. There's so many conditions that go back to first reducing inflammation, which can start with the mouth, and also getting good oxygen and good sleep at night. These are two books that I absolutely love. I think everybody should have a look at these. One is called The Inflammation Syndrome by Jack Callum, who really talks about inflammation as the thing we should be looking at even before we're looking at things like cholesterol and other typical data points that most physicians are looking at. Beating the Heart Attack Gene by Bale and Deneen, who completely turned the cardiovascular world upside down by proving that inflammation was a key factor in heart disease. And that heart disease could actually be reversed if we could indeed reduce inflammation in the body. So the point at which your dentist can help you is obviously by reducing bacterial loads and inflammation in the mouth. That's where every general dentist comes into play. But the other place that general dentists can come into play is through airway management and understanding that the structures of the back of the mouth actually are the gateway to the airway. So everything has to pass through a smallest point in the airway. And typically, that's going to be at the back of the nasal cavity where dentists can see, and the back of the oropharyngeal airway or behind the tongue and around the area of the soft palate, tonsils, and adenoids. So the dentists are looking at these structures every single day and every time they look at your mouth. And so they're very often a good judge to tell you, hey, you might have a compromised airway. Some of the things that you should be looking for: snoring, gasping during sleep. We know that OSA likelihood increases with age. It's associated with larger neck sizes. The likelihood increases with weight gain. And I do want to make a point about this. You do not have to be fat to have obstructive sleep apnea. It is an anatomic problem. Weight contributes to it. Weight loss can certainly make it better, but typically there are other factors at play, which really revolve around skeletal patterns, where tissues are located, anatomic factors like the tonsils and adenoids, and physiologic factors that really are, a patient's muscle control and muscle function that come into play. It is not just all about weight. But if you're a male, you're at higher risk. People with jaws that are set too far back, we call that a retrognathic mandible. People with jaws that are too far back are at higher risk. People with underactive thyroids, people with gastroesophageal reflux, people with type 2 diabetes, and other cardiovascular disease. Sleep apnea is usually there in a lot of these cases, and very often up to 10 years before patients are treated for any of these comorbidities, which is kind of crazy, JB, because our model has been so focused on just treating disease versus preventing it. And
That's right.
so when dentists start their journey and start learning about the oral systemic connection and how to make their patients healthier, the first thing that really goes through our mind is, well, there's 40 million reasons why we should be paying more attention to airway and the oral systemic connection, because we know how many people are out there with suspected disease. Basically, 1 out of every 3 patients that walks into a dental office will have some level of sleep disordered breathing. This is a fact that crosses almost every population group, and not every age demographic. It's certainly more prevalent in adults, but it's not to be ignored in children because it is quite prevalent. But in a general practice, 1 out of every 3 people that walks through the door of a dental practice will have some level of sleep disordered breathing. And we know only 10% at this point have typically been diagnosed. The craziest thing is that of that 10%, only 25% are ever successfully treated. So in essence, we've only treated 2 or 3 out of every 100 people successfully. And when I share what a burden this has been on our healthcare system, really our greatest healthcare burden may not be heart disease. It may be what comes before heart disease. It may not have been COVID. It may have been some of the underlying factors that contribute to so many other diseases, a condition where we're only successfully treating 2 or 3 out of every 100 people who have the condition, and yet CPAP alone is a $6 billion a year industry, and we're only getting it right 2 to 3% of the time. So dentists are really in a great place to stop that. In the current model, the issue is that if you're not obese, and you don't come in with this hard question to your doctor of why am I snoring so loud, or why am I not able to sleep, um, you're really not likely to have a study that can tell you what's going on. In fact, they did a study where they took 100 primary care physicians, and they who were actually screening for sleep apnea. More than a third flagged as high risk, and yet only 2% of those were ever even sent for a sleep study. They were more likely to get a psychiatric consult than they were to get a sleep study, which is pretty scary. We know people with OSA use hospital resources way more than patients who don't have OSA. They use hospital resources generally at twice the rate of other patients, and they do that up to 10 years before the diagnosis ever comes along of obstructive sleep apnea. And we also know that hospital stays for patients with undiagnosed OSA or uncontrolled OSA is almost 3 times longer than for someone who is otherwise treated and diagnosed. We know we can make a difference all through life, and every age population, there are consequences. During pregnancy, we can see gestational diabetes from OSA, pregnancy-induced hypertension, preeclampsia. There are risks to the unborn child. If a mother snores habitually, she's going to deliver a developmentally delayed baby 7% of the time. And even if they snore occasionally, that's 2.3% of the time.
Hey, Jeff, can I ask you a quick
Yeah,
question on the
please do.
pregnancy
I
piece?
don't want this to be just a lecture,
No,
but
you're good. You're good.
yeah.
I've got a couple questions at the end, but on the pregnancy piece alone, do we have any data about how many of those women likely had OSA before becoming, do you know what I mean? Like, what's the correlation? We know weight
We
gain
don't know because so few
gets
pregnant
screened.
women are even tested. So certainly if you
Yeah.
go back to pre-pregnancy, then most of those have never been tested. You're talking about a young population.
Yeah.
And again, that younger population is almost ruled out from having obstructive sleep apnea for most of the medical world. It's not even a consideration. A sleep problem is treated with medication or with behavioral therapy. It's never looked at as a potential problem. And then very often, even though the literature that I'm quoting on pregnancy has been very well documented in the gynecological world, and the obstetric world, we still don't see the level of testing that we should. And yet we do know that the prevalence of preeclampsia and gestational diabetes. And how easy would it be to screen, not even with a full-fledged sleep study, but with a non-invasive overnight pulse oximetry test?
Absolutely. There's so much within the pregnancy world that we could talk about, but I do think if you had if there's any PSA for women in that age demographic, if they have snoring or other signs or symptoms that they're having poor sleep quality or sleep related issues prior to getting pregnant, I would imagine pregnancy will only make those things more difficult. It takes a perfectly healthy young female and makes sleep impossible, and you're gaining weight, there's compression on a lot of body organs, there's a lot of sleep postural challenges that come along with it. So it can take a healthy person and make it kind of dicey for a few months. So I would imagine if there's any predisposition to that before getting pregnant, if you have any signs or symptoms of the things that Jeff's talking about tonight, getting tested if you have the luxury before getting pregnant or while early in your pregnancy so that you can protect yourself and your baby while going through that gestational period would be truly advantageous, I would think, right?
Yeah, absolutely. And on both sides. So for dentists who are listening tonight, I love overnight pulse oximetry as a screening tool for anyone who might be at risk. Now, it's generally frowned upon to just use as a general screen. Like, we don't just hand that out to everybody, although truly there's no harm in doing that. I mean, when we take vitals, we look at people's oxygen. So why would
Yeah.
we not want to know what their oxygen is overnight? And it doesn't mean we're diagnosing anything. We're just identifying a problem that can be contributing to other things. I, for a long time, have offered free overnight pulse oximetry testing to every one of my patients.
You can do it with your Apple Watch. Like,
Yeah. And that was my other point, is
you
that
know,
these kinds of tools have become so prevalent and so available to the
yeah,
general public now that why would you not take some of these healthcare matters into your hand?
absolutely.
Just making sure you're getting the right oxygen and I could be the difference between a healthy pregnancy or non-healthy pregnancy, or complications, during gestation, or even, after delivery. So, it's not just about the health of the mom; it's the health of the developing fetus, and we know that healthier moms lead to healthier babies. So, very important. But when kids are born, very often we can begin to see sleep disordered breathing problems. If a child has a really bad tongue tie and they're not able to swallow correctly and not able to breastfeed, those children generally are not going to develop as well skeletally, because it's that swallow pattern that actually stimulates lateral growth, which is the floor of the nasal cavity. So, there are things that we can look for during infancy, but certainly as children aren't able to swallow well, as they develop throat infections or enlarged tonsils, that can compromise the airway. And this stuff just builds one thing on top of another. And so I urge parents, if you have a child with a lot of respiratory infections, ear infections, if they're waking up a lot during the night, kids are programmed to sleep, and if they're not sleeping through the night, something's going on there. If they're not doing as well at school, if they're showing hyperactive activity, and getting that slap diagnosis of ADHD, which we're seeing so much of. Look at sleep first, before we go to a medication. If they have frequent allergies, enlarged tonsils, a bad gag reflex, constricted arches, or a crossbite, we should be looking for these things. Dentists, as early as we can find them, we should be correcting these things. And parents, we should be looking for the sleep disorders that might be there, that the first hints of are a child just getting out of the bed, several times a night, or certainly hearing any snoring or disrupted sleep, and God forbid gasping. We certainly don't want to hear that coming from children. The airway is typically as good as it's ever going to be. So this is something we should be looking for in children, because we can very often intercept it, as I had mentioned at the beginning of the show. And certainly there's changes during adolescence. A lot of physicians will say, well, the tonsils will go down, they'll outgrow it, the airway will get better, but at what expense? We know that growth hormone is produced during deep sleep. And if a child is not getting good sleep because they're not breathing well, they're not producing enough growth hormone. So they're under the growth curve. So what price are we paying to wait for the tonsils to go down naturally? And how much skeletal development did we lose? And how sick will they be as an adult? And how hard will the orthodontics be to correct all those things because we didn't pay attention to it earlier? So something we should definitely be looking at. And so we don't need to stop looking at our adolescents either. In early adulthood, sometimes these things get worse because of either alcohol or drug use. People get on worse schedules. But again, there's a bias within the medical profession for young adults. Certainly the first question they're not going to ask about is obstructive sleep apnea. So should be looking for the same signs and symptoms, snoring, poor sleep quality. When we get into adulthood, those are really the first signs that we're looking for, are snoring and daytime sleepiness in general. A third would be gastroesophageal reflux. But as kids get into adulthood, here is the likelihood that you would be diagnosed with OSA if you have any of these conditions. So just by having high blood pressure, 30% likelihood that you already have OSA. If it takes 2 or more drugs to control your blood pressure, or you're still spiking despite being on a blood pressure medication, 83% likelihood that you have it. Patients with heart failure, 75 to 85% likelihood that you already have OSA. If you have atrial fibrillation, half of you have OSA already. If you've had any type of ischemic, meaning clotting heart disease, almost 40% of you already have OSA. If you've had a clotting stroke, 92% of you have OSA. I mean, these are statistics
That's
that
a
have been out.
huge number.
That is a huge number. And it amazes me how many TIA and stroke victims have never had a sleep study.
Yeah.
And there is no greater risk factor as a predictor of future heart attack or stroke than undiagnosed, untreated OSA.
Right.
So if you have metabolic syndrome or type 2 diabetes, about half of you will have OSA. Which is a major contributor to that. But if you happen to be an obese diabetic, that likelihood is 70%. And if you're morbidly obese as a male, 90% likelihood that you have OSA. As a female, 50%. But this is a biggie. Just if you have reflux that needs to be treated daily with a proton pump inhibitor like Protonix or Nexium or one of those type of drugs, the likelihood is 60% that you already have obstructive sleep apnea. And if it's worse at night, that goes up to almost 90%. So again, not just for the public. Yes, the public, I want you to be your own healthcare advocate, but dentists, ask these questions of your patients, because gastroesophageal reflux has such an impact on the dentistry that we do.
Absolutely.
And the wear of teeth and erosive lesions and the longevity of the work that we do. We are already looking at reflux. So why are we not then saying, listen, with this diagnosis and the fact that you're having to take these medications, let's get you referred to somebody who can do a sleep study for you, or let's make a sleep study possible. So there's so much information like this. And again, I didn't want this to be a lecture. I really wanted it to be more of a discussion, but there's so much information here. And I love this slide because as we get into our senior years and the risk for heart attack and stroke increase, I just want everyone to know that there is no other risk factor greater than OSA, undiagnosed or untreated OSA. If you have undiagnosed or untreated OSA, you have 23 times the risk of controls of having a future heart attack or stroke. Nothing even comes close. Smoking is less than half of that risk factor, and hypertension is only a third of the risk factor. So, right. And so what are the things that we're looking for here? Why are we not asking the OSA question more? So, this is a disease that's about oxygen, but it's also about sleep quality. We know 1 in 3 Americans are not getting enough sleep. We know that most of the time that so many of the sleep disturbances can be attributed to OSA, and not just a blanket diagnosis of insomnia, which gets medicated many times in a way that can make sleep apnea worse. So we know the number of people that are affected by this. And really the take-home message is that right now we are spending somewhere between $65 billion and $165 billion in healthcare resources on undiagnosed or poorly treated obstructive sleep apnea. And that starts with $6 billion on the CPAP industry, which we're only seeing about 25% effectiveness from.
Mhm.
And it just falls down to so many other factors, absenteeism from work, and then certainly, the healthcare costs, the emergency room visits, the heart attacks, the strokes, everything that's going on out there. And so my message is, don't let diagnosis scare you. You don't have to go to one of those crazy sleep labs anymore. I understand that that's very intrusive, and it's really a limiting factor for a lot of people. Diagnosis can be made with something as simple as a ring on your finger and an app that connects to a sleep care physician and a sleep specialist that can diagnose you with sleep apnea and then send a prescription to the appropriate person for you to be treated. And so don't let diagnosis scare you.
Hey, Jeff,
And
for
yeah,
that ring, do you have to get that prescribed to you from a doctor? Is that something available over the
great
counter?
question. Yeah, perfect question. So in some states, dentists are able to give out a home sleep test device. In other states, they are not allowed to do so. What I do know is that in most every state, if the dentist gives it to you, it will not be reimbursable by medical insurance. So what we typically do is we work with our healthcare partners. We make a referral for one of them to actually request the home sleep test. It can be mailed to most patients. And then as long as a board certified sleep physician interprets that report and writes the prescription, then not only can the sleep study be covered by their medical insurance and Medicare, but also sleep appliances like the ones that we make in dental offices, as well as CPAP or Inspire, which a lot of people have heard of. All of those things can then be covered. But what keeps most people away from diagnosis and treatment are two things. One, fear of the test, not wanting to go into a lab,
Yep.
and then fear of the mask, not wanting to wear,
For
the
sure. I
CPAP.
mean, the sleep center is kind of a invasion of your privacy a little bit. Like to have somebody watch you sleep is an uncomfortable thing, and I can appreciate that. That definitely would be a rate limiting step for a lot of people to want to go into a sleep center. Didn't you say when you came back from AADSM that it's probably likely pretty soon that we're going to see this as a consumer item? Like we'll be able to order it on the internet?
So, yeah, I mean, they already can. A
Okay.
lot of these things are available. They are medical devices. So anything that can truly diagnose sleep apnea, and let me be clear, dentists, it is not within their purview to diagnose
That's right.
sleep apnea. Our job is to help identify some of the leading causes of sleep apnea, get a referral for the proper sleep testing, have a sleep specialist, a board certified sleep specialist, diagnose that study, and then send the appropriate prescription for treatment to a dentist that may be treating sleep apnea, or to a durable medical equipment provider that can provide CPAP, or to an ear, nose, and throat physician that may be able to provide Inspire therapy. So, we don't want to step on any toes, but yes, dentists can give these out. They are available to the public, but then you get into this thing. If you do it on your own, none of that data can be used,
Sure.
to
But if
then,
you want to pre-screen because you're not sure if you have something going on and before you commit to,
yeah.
because honestly, Jeff, at least in our community, it's taking folks a really long time to get into sleep doctors. They're so overwhelmed. I mean, your statistics validate the prevalence of the disease, but they also probably highlight the fact that we don't have enough clinicians to treat the disease process.
Exactly.
So they can't get in, they can't get to see the physician for 6 months. Sometimes there's challenges getting their MDs to refer them to that, so they could do a quick screen, so they have data to back up, their justification for pursuing a sleep study. So Aura rings, I would imagine, give you some relatively
Yeah,
decent
we're getting
information.
so
Whoop
much good
bands.
information. Yeah, so there are FDA cleared devices for the diagnosis of sleep apnea, and really, as a medical device, that is not supposed to be sold to the public.
Right.
That is really for the medical profession to use in the diagnosis. But there are so many of the home test devices now that are giving us data that are almost at the level and of the quality that we're getting with some of these true medical
Yeah,
devices, that it makes no sense that we wouldn't implement some of these.
that's right.
And what we've seen over the last couple of years, what has come out, and the low cost of some of these devices, we're even starting to look at giving one of these devices to every single patient that we make a dental appliance for, just so we can have ongoing monitoring without having to send for another sleep
Absolutely.
study and incur those kinds of medical expenses.
All right, are you game for rapid fire?
I am. Let's do it.
Okay. Melatonin.
B.
Now, no, not B.
B.
Melatonin.
No, the question is, the answer is always
Answer's
B.
always C.
Oh, okay. If it's A, B, C, D, E, then yes. If it's A, B, C, D, then it's B.
Noted.
Yeah, yeah.
That might explain some of my scores. Okay, anyway, um, let's talk melatonin. Couple of
Yeah.
of highlights for that. Um, Legally available hormone for purchase. What does it do to sleep cycles? What are the pros of the use of melatonin? What are the cons of melatonin, and specifically in kids?
So, great question. Melatonin is something that we produce naturally as human beings, and what stimulates the production of melatonin is the absence of light. So this is why we encourage good sleep habits. This is why we say no blue lights, no screens in the room, no any kind of external factors that can cause flickering in a background, anything that takes away, anything that takes away from the body to recognize that light does not exist anymore. That's our natural circadian rhythm. In that absence of light, the body produces melatonin. Melatonin actually helps us to induce sleep. There are other chemicals that we produce as well that help with sleep induction, but melatonin as an adjunct can be useful. I caution people that at too high of a dose, it actually can change normal sleep cycles. So, where we have light sleep, deep sleep, dreaming sleep, it typically leans us more towards dreaming sleep. And for the most part, apnea is worse during dreaming sleep. I don't have time to get into all the reasons for that. And so when we see patients taking too much melatonin, they get into these crazy wild dreams, but it can also make their apnea worse. But usually 5 milligrams as a supplement is not a bad place to start. I generally stay away from it with kids. Kids are programmed and they really need a strong weight in deep sleep. Deep sleep is where we produce all of our hormones and regulate all of our neurotransmitters. And by the way, serotonin and melatonin are very closely related. So people who are serotonin deficient will also be melatonin deficient. And it's crazy how just getting the sleep cycle back in line will increase serotonin levels because of improved deep sleep. And then that in turn increases melatonin levels, which then makes everything better. So hopefully that answered it. Not a quick answer, but a quick question.
No, I think that's great. I usually explain it to you like if you're taking melatonin, it can elongate the REM cycle and not allow you to do that deep drop into deep.
Right.
And all the great stuff happens in deep, the repair. I mean, As adults, that's, and kids were most concerned about growth hormone and all the things that are happening during that state. But as adults, we're also super concerned with the reparative piece of that deep sleep, because that's what kills cancer. That's what, or keeps cancer at bay. That's where a lot of the detox from our daily activities and all the good stuff that happens. If we're not dipping into that deep reparative sleep, we're really missing out on one of the very important parts of why we need to sleep.
Yeah, really, I mean, we could do a whole weekend
Yeah.
course just on the stages of sleep and what happens in each stage. But really, and especially in children, that deep sleep time is so critical for proper growth and development, and for adults too. We need that for balancing all of our hormones and neurotransmitters, and for cardiovascular rest.
Easiest way for dentists to start pre-screening their patients for sleep.
Just look.
Yeah. What
Just
are like, if you had to rattle off 3 things that if you looked in a mouth, you probably are already. First off, I was going to say add it to your health history. That's number 1, because
yeah,
like, that's stupid easy.
yeah.
Just put the question on there. Do you have sleep apnea? Do you have sleep related issues, or do you snore? At least you're screening for these things, right?
Right. And if I were going to pick 3 questions on that is, do you snore regularly or loudly? Do you feel tired during the day? And do you have, or are you treated for gastroesophageal reflux? Any one answer to any one positive answer to any one of those things
Yeah.
already creates a high likelihood. 70% of people who snore regularly or loudly will test positive for sleep apnea statistically. So, dentists, great questions to ask to start. But the first thing I tell dentists is, just do what you're already doing. You're already doing an oral cancer screening. You're already looking at the size of the tongue and the shape of the tongue. You're already looking at the back of the throat. You're already looking at the tonsils. You're already looking at how big the dimension is of the airway back there. Just make a note of it, because someone who has dimensionally a small airway to start with is going to be at higher likelihood for apnea. Someone with a larger tongue is going to have apnea. If you're noting that they have a retrognathic jaw, or a mandible that's too far back, that's already a large risk factor. So, there's so many things that just by doing what we're already doing, we can recognize some of the greatest signs. You combine that with what you said, JB, just asking a couple of great questions on the medical history. You're already screening for a lot of potential sleep apnea.
All right, last question. If
Mhm.
you grind, you didn't give me a percentage. If you are a grinder or believe that you have some type of grinding disorder, as a kid or an adult, your likelihood of being sleep apneic or a sleep related disorder is what?
Great. That's actually a great question. I do not have a number
I
on
bet it's
on
like 90%.
Yeah, well, so we know that apnea contributes to grinding. The reason is, every time you have an event where your oxygen drops, body kicks in fight or flight, and accessory muscles start to work. So we get what's called an arousal. We get a lot of muscle response. So we can see body movement, and particularly the muscles that control the jaw. So the
The re the
problem, yeah,
the
the
reason
problem.
I would say it's high as well is that, what are one of the 17 data points that they look at when you go into a sleep study? It's chin mobility, right? You have
Right,
a data point right here, because lack of chin mobility indicates deep sleep.
that's right, and lack of masseter activity as
Correct. So
well.
if you are in deep sleep, your likelihood of OSA is really low.
Yeah,
If you stay within that REM, like,
yeah, it's too much time in REM for most patients is going to create a higher likelihood for
right.
OSA.
And
But
that's
there's still a good, I mean, For some people, it's bad in deep sleep as well. I mean, if just because the chin's not moving, if it's too far back, the base of the tongue is
For
attached to the
sure.
lower jaw, and the base of the tongue could still be obstructing the back of the airway. So the answer is this. I don't know the exact percentage of patients that grind who have OSA because I don't think we have enough data on that.
I was going to say, sounds like we need to be doing a study.
Yeah, but what I will tell you is that it is probably one of the biggest contributors to grinding. And before just making an appliance to fix grinding, we should be testing for OSA.
Love it.
And the reason is because some of the traditional methods for making a night guard and treating grinding that we've had in dentistry can actually make apnea worse if it is not made correctly. So
Yeah.
we do know that patients who have been diagnosed with apnea that have a night guard made for grinding, we know that more than half of them, their apnea will get worse with that night guard in place. So that statistic we're very sure of. What we don't know yet is how many of those bruxism cases are truly sleep apnea. We just need, really, that needs to be a broad scope, multi-location study
Which you
across
should be
different
able to,
populations.
you should be able to pull that from sleep studies,
Yeah,
I would
yeah.
think.
You could, but how many of the bruxism, you also have to say how many of your bruxism patients have been actually tested.
Yeah,
And that's the problem, is how many have not been tested,
sure.
which is why we don't know what that true percentage is. So I think it's going to take a multi-location study on every patient that presents with bruxism being tested blindly, and then developing a statistic from that. But yeah, we shouldn't be treating bruxism without ruling out apnea, which is, I think, the point that you were trying to lead me to.
Yeah.
So thank you.
You're welcome.
Nicely done, as
Thanks.
always.
Jeff, killer show.
Yeah, I think it was good. I tend to rattle when it comes to this. Obviously, everyone can.
Passion.
Yeah, everyone can see that this is a passion of mine. It's truly a healthcare burden. I don't think there's any family in the world that has not somehow been affected by sleep apnea or what has come as a result of undiagnosed or untreated sleep apnea. There's certainly many social factors that come into play. Families or spouses that don't sleep together anymore. There's so many things that could be addressed in overall well-being, not just from a health perspective, but from a psychological perspective, and from a social perspective as well, just by looking at this. And dentists are really in a great position to do that. And again, not to be a substitute for your healthcare practitioner, but to be a good healthcare advocate, and as a referral source to be working with your healthcare practitioners in identifying these conditions.
I could listen to you talk about sleep for hours.
And you have.
Yeah, it's that we're now going on like 30 hours.
Yeah, yeah.
At least those I get credit for.
Yeah, nothing tonight.
Nothing tonight. A big fat goose egg. I learned something every time we talk. Every single time I learn something. Why? Because the data is moving constantly and things are changing. And, as general dentists, we cannot stay dialed into every single subject matter that we come across on a daily basis. So we depend on people like you who have found that niche, that subspecialty, that area in our world that you love and are super passionate about, to kind of keep bringing the information back year after year and saying, here are the updates, here's what's going on, here's how we keep you current, so that general dentists can continue to do their best job of educating, screening, teaching, and caring for the patient populations that they're serving. So on behalf of all general dentists and the thousands of people that you have touched with your teaching. I just want to say thank you. You changed my life, and I know you've changed many others as well.
Oh, that is very
And
nice
with
of you to
that,
say.
Dinks,
Yeah.
we must say good night.
And JB, tell everyone how they can reach us if they have any general questions or want to get in touch with us.
Smoke signals.
Smoke signals. That works
Yeah,
really well.
that
Yeah.
works so well. No,
Yeah.
if they want to get in touch with us or learn more, obviously comments or responding on our YouTube channel, we'll see those. You can go to dentisintheknow.com. There's a form you can fill out there to reach out to any of the three of us. And then we're on all the social channels. You can find us there. Send us a DM and let us know what's on your mind. We'll be sure to get you connected with the right people.
Missed you, Chad Duplantis.
Oh, my head. Oh, wait.
Yeah, put your head up. There's
Maybe
Chatty.
he'll come back and be in Dennis in the Know someday soon. But until then, it's just us two dinks. Have a great night.
Have a good night, everyone.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, dinks.